Good morning, good afternoon, or good afternoon to everyone, depending where you are. My contribution will be a sort of survey of what is the intracavitary EKG method for tip location. This is a story which began a long time ago. I've tried to summarize this story in this review, which was published recently on Journal of Vascular Access. And the beginning of it all was from a paper in 1949 from a guy called von Hellerstein working in Cleveland, Ohio, who did the first experiment, the first test to see whether it was possible or interesting to record the intracavitary potentials using a catheter filled with cell line. In this paper, the electrical connection was achieved by cell line column method. Still, there was a previous report in which they used a thin wire. This paper usually considered the beginning of the intracavitary EKG tip location, though there is actually no mention of the possibility of using this method for tip location. At the very beginning, it appeared to be a method for sophisticated diagnosis of arrhythmias. Then there is a period which some 20-year span from the 80s to the beginning of this century, which I like to call the prehistory of tip location with the EKG. In this period, we had the first clinical paper in the 80s from Japan, from Germany, from Spain. You see that most of these papers come from Europe, with some spare exceptions, like this Francis paper, and particularly from Spain and from Germany. All the other methods for intraprocedural tip location, intracavitary EKG is the best. It is accurate, is more accurate than radiology, as shown by those three papers from the beginning of this century. Is somehow less accurate than transesophageal echocardiography, but obviously transesophageal echocardiography is not regarded as cost-effective for tip location, for everyday tip location. It is inexpensive, easy to perform, easy to learn, and it can be applied to any catheter. And this is very clearly said by many guidelines, including the standards of the Infusion Society. There are still some limitation of applicability, basically in adults, not in children and neonates, because the conventional intracavitary EKG technique cannot be carried out where the P wave is difficult, impossible to identify. This situation is usually atrial fibrillation, but very recently, a few very interesting papers, one of them from my group, have shown, always using the transesophageal echocardio as a point of a standard, that modified intracavitary EKG may replace conventional intracavitary EKG. I will not say much about this, it would be too long, but just to summarize, instead of looking at a P wave, you will look at the height and the frequency of the F waves and the atrial fibrillation waves. Though there are some situations in which the conventional intracavitary EKG is not applicable, but there is no atrial fibrillation. So in this case, for this pacemaker, etc., we must have some other option.